آقای دکتر سلام عرض کردم. Hello, dear Maria. How are you?
I'm fine, thank you.
Very welcome to our meeting.
Thank you.
You're welcome. I will give the opportunity to Dr. Parkis to introduce you, and very thanks to you come. And before the started, I should ask all the participants to mute your mic, please. خواهش میکنم از شرکت کننده ها لطف کنید، خواهش میکنم لطف کنید میکروفونتون رو آف کنید، صدای خیلی بیرون میاد. خواهش میکنم صداتون رو آف. خیلی ممنون. آقای دکتر پرهیز. Dear Maria, how are you? How is the situation? You're welcome. Can you increase the volume of your voice, please? Yes, now is very good.
It's okay? Okay.
Yes, it is very good now. And very thanks you are accepting our invitation for this meeting. And we are very glad to have you. I have seen you 2 times, once in Iran 2 years back, and a few months back with Dr. Krishnamurti. You got a very nice meeting with Dr. Robert Mann. Is it, you remember? Yes.
Of course, I adored Iran.
Yes. How do you like Iran? Did you like Iran?
I loved it.
Very good. Hope.
The country, I loved the people. It was wonderful.
Very nice. Thanks of you. This is your kindness, and hope the situation will change. Again, we will have you at Iran, and we will see you in Iran in our association, our Congress.
How is the COVID situation in Iran now?
In Iran also, most of the state is not so good, and the number of the cases every day is increasing, but the mortality is decrease. How is it in Italy? How is your country?
Now it's really doing, we're doing very well. There are it's been almost a week with no deaths, and it's sort of under control, but we're all wearing masks. We're all being very careful. So no meetings and masks inside closed spaces. Careful in the hospitals.
Yes, yes. Dear Maria?
Yes?
Yes, you were saying about your country and the mask is it the activity is same, is university, dental school, everything is carrying on, or still is holiday?
Well, being August, it's holiday, so the universities would be closed anyways. We don't know about September though. It's still a question mark, so we don't know what's going to happen September, October. We'll see.
Oh yeah. Now in Iran, we are in the summer. It's very hot. Sometimes we got 40, 45 degrees centigrade, and the number of the cases are increasing, and our school is closed. But some of the examiner for examination for the residency and all, it's maybe it will be held in next month, but maybe by internet. I don't know whether they are going to announce to attend the examination or not. How is in Italia? Italia is examination is by
now everything online.
Online, yes, everything
online. School online, university online, everything online.
Yes.
Only we can't work online, so we have to work on the patients, but otherwise all the people that can do something online do it online.
Yes, yes. Hope hope it will go off soon.
Yes.
And we will wait for the vaccination. I don't know whether the vaccine will come or not.
Who knows?
Yes. Yes. I was waiting for Dr. Parhiz to come, and he got some problem with his VPN because this Zoom in Iran is filtered, and we should use VPN for that. And he got some problem. If you wait for a few minutes.
Absolutely.
Yes. Thank you so much for your patience.
Don't
I
worry.
will show you some photo from different parts of Iran.
Wonderful.
I hope you will like it. This is my place. I am in Yazd. This is Shiraz. I don't know whether you have seen Shiraz or not.
I have.
This is a very nice place, and it was famous with the wine also during Shah time, but not now. Sorry. Hello? چی شد؟ الان بهتون I'm sorry for interruption. This is my place. I am staying in this place, Yazd.
I haven't been there.
You've been there? Very good.
No. I have not been there.
Oh no. I hope next time. I hope next time once you came, we will see you in Yazd also. It's a nice place. It's a historical place.
I was in Shiraz and Persepolis and in Ishvan, and then Isfahan, of course, but that was it. Hey.
Yes. Yes.
Hello,
Dr.
Professor.
Hello.
Good night. How do you do? Nice to meet you again.
Nice to see you again online.
Yeah.
Better than nothing.
Thank you so much. Thank you so much for accepting the invitation. And I hope we can have a very nice presentation together tonight for my colleagues in Iran.
It's an honor. It was so great 2 years ago. It's been one of my even my husband still remembers the trip. It was so
Yes. Yeah, I have your pictures you sent me by WhatsApp 2 years ago. Unfortunately, I couldn't connect with my laptop, so I cannot send this photo to my colleagues. I'm trying to connect on the laptop. Then I will show you the picture you sent me 2 years ago.
Thank you.
With your husband. You're welcome, Professor.
آقای دکتر اگر میخواین معرفی کنید الان حدود 23-4 نفر اومدن تو. میخواین برنامه رو شروع کنید؟
بله بله. Okay, my colleagues, let me introduce Professor Moazzini. Professor Maria Moazzini is Scientific Director and Orthodontic Consultant for Craniofacial Anomalies and Smile House, Cleft Lip Palate Center, Santi Paolo Carlo Hospital in Milano, and at the Department of Maxillofacial Surgery, San Gerardo Hospital. She is adjunct professor in craniofacial anomalies for the residency in maxillofacial surgery and orthodontics, University of Milan. She is president of European Cleft Lip and Palate Craniofacial Association and representative for the European Reference Network. She has acquired a specialty in orthodontics and dentofacial orthopedics and a master in medical science in 1991 to 1995 in Harvard University. And she completed a craniofacial and surgical orthodontics fellowship in University of Illinois, Chicago in 1995 to 1996. Professor Moazzini, thank you again accepting the invitation, and we are waiting for your presentation.
Thank you. Do you want me to share the screen?
Yes, wait,
Yes.
I just make you as a host. You can? Yes. Yes.
Almost there.
Yeah.
Still
Yes,
not.
yes. Yes, it is okay. We
We
can
have
see.
your slides clearly. Thank you.
Wonderful, wonderful.
Yes.
Okay, so I'll go directly. The title, you've all read it. These are some of the pictures that I took when I was in Iran 2 years ago. And there's myself and Professor M. Hemprich up there during the meeting. And then some of the pictures of the beautiful, beautiful places in your beautiful, beautiful country. And if you look at the girls on the right side, you see how wonderfully nice everybody was to us, especially younger generations were lovely to us. So I deeply thank you again for 2 years ago. It was a great experience, and I hope to share some of what I've learned.
Sorry, dear Maria, I am sorry interruption. Because I introduced you as a host, please permission me to record.
Sure, absolutely. Absolutely. Yeah. No worries. Yes, so the topic that we'll talk about today is when we treat a child with a bilateral cleft lip and palate, we all know that it's a long way, a long journey, and the topic is, can a good coordination between the orthodontist and the surgeon reduce the total burden of their care? And I will go step by step following growth of these children and seeing how much a good coordination between us can really reduce their burden of care. So we'll start with infancy. And yesterday you had Professor Krishnamurti from India, and he's a big fan of nasal molding. And as I said in one of my replies, I have quite a lot of experience in bilaterals, less in unilaterals, but I'll try to share with you what I know about bilaterals.
Please, Maria, please 1 minute. I'm very sorry because you are a host. I cannot record this video. I have to bring you out few minutes.
Okay, I will wait.
I am sorry, yes. I think you have to now make me host. Now you are a host. You check on the up on your click on my photo and see.
Click on your photo. I have. Chat, rename, pin. I've clicked your photo.
Yes, on the blue button,
Yeah.
you can make me as a host or co-host.
Make host.
Yes.
Co-host. Okay.
Host is okay.
Do you want to make the co-host?
Host.
Host.
Yes.
Host then. Make host. Yes.
Thank you so much. Now you carry on.
You're very welcome.
I'm sorry.
Don't
I'm
worry.
very sorry. And this, I should announce also this live. It is live on YouTube also. If anybody you can introduce this to the others. I have sent to you, Dr. Paris. You can send the link to the others.
Yeah, of course. Professor, now some of my colleagues are in the waiting room. Would you please accept
Yes,
them?
yeah, they're accepting. I will make you also co-host. You can also accept them.
Thank you. Thank you.
You're welcome. Very sorry, dear Maria. I am very sorry. We are not very familiar with this Zoom. Recently, we started, and I am very sorry for the interruption. Thank you. You can.
Once you're ready, you tell me.
Hi, Dr. شما هم الان هستید. We are ready. Thank you.
Yeah. Okay.
Yes.
You can start.
We just were saying that we'll start with infants, and some type of infant orthopedics in bilaterals is always useful, because when you have a child with a very protrusive premaxilla, the surgeon really has a hard time closing the lips in a proper way and obtaining a good muscular reconstruction. So what you don't want to do, though, is retract the premaxilla so that the nasal spine comes back with it. So, and another reason why you would like to get that premaxilla back is that you would like to avoid, avoid lip adhesion. Why? Not because it's a bad surgical procedure, but because right now there are 4 big randomized clinical trials going around the world looking into neurotoxicity of neonatal anesthesia. So even if we don't have the results of these 4 randomized studies yet, we do have a big doubt. So when in doubt, if you don't have to do an extra surgery, try to avoid it at all costs. We know that we could just use a tape and a passive plate and obtain a very decent result. But what's the problem with that? The tip of the nose comes back, the columella stays very short. And so even with a great surgeon like I used to have, Professor Bruzzati, you have a beautiful lip, but the nose has a very short columella and it's very flat with no projection. So in 1998, 1999, more or less, with Professor Bruzzati, we talked about using a modification of the cutting and Grayson technique. I had the luck of experiencing in Chicago, together with Dr. Figueroa, a modified way of doing nasoalveolar molding. And then I modified it a little bit more because in Italy, there's no way you can see a child every week. So you have to set your nasoalveolar molding so that you see the child once every 4 weeks. Sometimes if they live in Sicily, for example, once every 5 weeks. And it was very useful to have this kind of nasoalveolar molding now during the COVID, because I didn't need to see the patients as much and I could talk to them on the internet. So what you want to do is do the molding, but also associate to it a primary columella lengthening surgical technique. And Professor Bruzzati and also Dr. Utilitano now use a modification of the cutting technique. The idea was, if we do that, can we avoid secondary columella lengthening, which is a technique that I really don't like, even when it's well performed, like in this case. Usually with growth, get secondary deformities that you really don't want in those noses. The scar that you get in this area is really always not nice. So the rationale why we started, we had no data, there was no evidence, there were no randomized studies. So we started thinking that at least there was some rationale. First, there was the fact that the alveolar component is completely passive. And now there are some papers coming out. I'll show one from Professor Krishnamurthy. But the idea was that probably this passive molding, as it doesn't improve growth, but that means it doesn't inhibit growth. So that could have been, compared to Latham, it seemed to be a good idea. And then there was the nasal component, this idea of molding the cartilage, but more than molding the cartilage, what appeals to the surgeon is the stretching, the tissue expansion that you get within the nostrils so that the nasal lining is nicely separate, you can separate it easily during the OR. So you stretch those tissues, and what you get at the end of the stretching is a length of the columella, which is almost normal, a good position of the premaxilla, not too much retraction, you don't want too much retraction, and a good projection of the nose. This is another case. You see no columella whatsoever, protrusion of the premaxilla after the molding, the stretching that you get, and look here down, the length of the columella that you get, and the position of the filtrin, which is very close to the ellipse. And this is a closure by Professor Brusati. So what's the first question that we asked ourselves? Well, we're doing this, but then we really want to know if what we're doing makes sense. So we tried to see at 5 years of age, first of all, if the columella was growing like in a normal child. Otherwise, we would have stopped the technique and changed technique. So the first results that we obtained were comparing the previous children, a group of non-cleft children, these are my children, and the group of this new technique. So we had 31 bilateral children treated with the nasoalveolar molding, 31 treated with the previous technique, and 39 normal age-matched children. This is my son, actually, the profile of my son at 5. And what we measured was the length of the columella, the actual length of the columella, which was interestingly not significant, not different from a normal child, a non-cleft child. Even in terms of proportion, when you look at the base of the nose, the problem, of course, if there are lots of other measurements, but you can read the paper if you want to see them. But what was not good is the width of the nostrils. But if you look at other literature on children at that age, for example, the Mulliken paper on his technique, the width of the nostrils is even wider in the Mulliken technique. So we kept on going, and then we evaluated the length of the columella, so the growth of the nose in adolescence. So we had a group of 22 children who had reached 13 years of age. And at that point, we compared it with a group of 22 non-cleft children. This is my daughter at 5 and at 13. And on the left, you have the cleft, a bilateral cleft girl, and at 5 and at 13. And this is my son at 5 years of age. And you look at the length of the columella from the mental view, and look at how much the columella grows. So the proportion of the base of the nose from 5, so in almost 10 years, completely changes. So the columella is a fast growing part of the nose, and it has to be the same with our patients. And that's what we've seen. We've seen that the length of the columella in terms of proportion from 5 to 13 really grows and keeps a good proportion of the nose. The length of the columella at 5 and at the completion in adolescence has grown like in a non-cleft child. Again, that's my son underneath. But the problem is always the same. The width of the nostrils was wider at 5, and it keeps on being wider. So some of our patients, like this boy, do not ask for nasal correction, or like this guy who has not asked for nasal correction. but some do. Like, for example, this boy asked for nasal correction and has already gotten a very effective nasal correction in order to have a less broad nose, and also the tip of the nose was touched, of course. So of all the group of these patients, some of them want to, at the completion of growth, to correct the width of their noses, but at least they've gone through the whole growth and adolescence without doing any extra surgeries and without scarring at the base of the nose. And this is another girl who has not asked for any correction. So it probably does reduce cost. It depends on where you are. If you're in Italy with an orthodontist like me who costs basically nothing, it's probably very cheap. I know that Grayson was quite expensive, so I think it depends on where you live and the location. But in general, it certainly reduces the burden of number of surgeries that these children need to undergo. In terms of growth, the papers that are around, like Krishnamurti's paper at 7 years of age, together with Renu Palmar, show us that and we're doing the end of growth study, and our results are the same. There's no difference between the nasal bular molding and the non-nasal bular molding patients. But also, when you want to assess aesthetics, the idea would be having randomized studies, as I was saying yesterday evening. And I think the only people that can do that are Indians or maybe people from Taiwan. So where you have high numbers and you can randomize properly. So what I can give you is only a long-term longitudinal follow-up with well-kept records, which is, you know, the next best step after a randomized study. So we have started doing it also in unilaterals, not with Professor Brusati, but only with Dr. Autelitano. And we're starting as seriously as possible. So we do our nasal bular molding, and Dr. Autelitano does the surgery brilliantly. He's a very good surgeon. And we're trying to collect all our data in a sort of prospective semi-randomized study, but I don't think we'll have results for at least 3 to 4 years. And these two beautiful women that you see on top are two young doctors that are helping us doing the study. And actually, yesterday, Professor Krishnamurti was talking about how much you can straighten the, at least the columella. We don't know about what's behind it, but you can definitely get a lot of straightening with good nasal bular molding. But we don't have answers for that yet. And so it's still out there. Is it really worth it? We don't know, at least for unilaterals. It seems to be definitely worth it for bilaterals. So what's the next thing that an orthodontist can do for you in bilaterals? Well, sometimes children with bilaterals, thankfully not too often, it doesn't happen too often, have a premaxilla that grows vertically in excess. What we do know is that we should not correct when the premaxilla is protrusive in sagittal, in a sagittal direction. In that case, we should absolutely not touch the premaxilla, because we know that it tends to go back on its own during growth. But we also know that if there is a vertical excess, that doesn't stop. So it gets worse with time until it hits on something, and then it finally stops. So that should be treated during growth, because it is a severe psychological problem for the child, as you will see. We've published a protocol a few years ago, like 2010. So the cases at the time were treated in 2005, 2006. As you'll see, we've changed techniques, but basically during deciduous and mixed dentition, we tend to avoid at all costs surgery. So if you have a child like this one, at the time I used to use this rigid arm to compact the premaxilla, intrude and compact the excessive bone in the premaxilla. And what you would do is turn that screw, and the screw, by turning, would shorten up and lift up the two lever arms. So you could go from this type of occlusion to this type of occlusion, nice and flat, with a good intrusion of the premaxilla and a lifting of the nasal spine. So if you look at this nose and you look at after the intrusion, there is a mild, nothing to scream about, but there is a mild improvement also of the projection of the nose. But what's more important is how much you can get that premaxilla up, compact the bone. So it's really more of a bony contraction. And once you have contracted that bone, you can work with it orthodontically. And this is the same girl at 12 years of age with good occlusion. And this is the same girl at 21 years of age. She's actually now 25 and she's working in London. Many of my patients are very much into going to live abroad, as you shall see. But if you look at how already retrusive her mid-face is at 21 years of age without having done any surgery at the age of 4, you can imagine how much damage we could have done if we'd had operated on her, as the literature tells us, at 4 years of age, 4 to 5. This is another girl treated with the same technique. So an intrusion device was used with a fan expander instead of a regular expander because she needed more expansion in the anterior part of the palate. And then Professor Brusati did a gingival at 4 years of age, so procrastinating it with a good ossification. And we could do some early orthodontics at the time. And unfortunately, I could not follow her orthodontically because she went to live in another city, but we keep in touch. So she sent me these photographs and she's actually in medical school right now. I usually close spaces. I don't leave spaces for pontics. That's another little boy where we did the same technique, but we tried to make it a lot simpler. So we used anchorage through acrylic devices. So we had an expander with the acrylic attachment, and then an acrylic attachment at the premaxillary level. And then we used orthodontic wires to gradually, slowly intrude the premaxilla. And within a year and a half, more or less, in this child, we could get a total intrusion. In the meantime, he changed teeth. And then Dr. Autilitano did the bone grafting, bilateral bone grafting. And this is the child after the bone grafting. And this is a recent girl, actually, that I wanted to show you because I've refined the technique so that it's really much, much faster. It took me less than a year, and I could see the girl only once every 4 months. To me, this was very important because the girl came from Romania, and that there's a group of families, of Romanian families living in Italy, who hosted the girl and the mother as we made the appliance, but then she would fly back home and she would stay home for 4 months, and then I would see her 4 months afterwards. And I think that was very important. And this is the appliance again, the same that you've seen before. Oops. And so using an acrylic part at the front and an acrylic expander or a McNamara expander at the back, and wires to lift up the premaxilla. And this was the result. Look at the difference in terms of protrusion of the premaxilla and the good socked-in occlusion that you see here at the level of the canines. And if you look at the lateral X-ray, we have gotten quite a bit of retrusion as well. And you can see it from the, but you needed to get some retraction. Otherwise, there's no way that she got some retraction and also some protraction of the lesser segments. But this retraction is not enough to make me scared in terms of future orthodontics on the permanent dentition. So this is a very simple method that any good orthodontist could apply. And this was she before. This is the occlusion that we obtained. And this is her profile. I think that's my husband's clock. And this is her smile at the end of the intrusion. When the child is older, it really doesn't make any sense to do it orthodontically because we're in a rush because the canines are going to come in, so we need to put bone grafts, but we cannot put bone grafts with a premaxilla which is so low. So what I did in this case to help the surgeon, which was Dr. Mazzoleni from San Gerardo Hospital, was getting all the teeth out so that he would have a block of teeth he could use. So we did an uncovering of the central and the other lateral incisors, and prepared sort of a block of teeth that you see here, of the anterior teeth, that could be used to guide the new position of the premaxilla, which had to be higher up, but not completely back, because the child was only 12 and a half at the time of the surgery. So the mandible would grow, so we needed to leave it a little bit forward. We continued with the orthodontics, aligned the arches, and if you see, the mandible has grown a little bit more. And this is as the child was prior to treatment. This is at the completion of the orthodontic treatment. And this is him 12 years post end of orthodontic treatment. We had suggested to do a rhinoplasty because he was operated by another surgeon in northern Italy, but he still has not done anything yet, but he's quite happy. There's another group of patients where really we can make a difference if we work together properly. And that's when patients have wide gaps. And the only way to do, in this case, bone grafting would be to do a premaxillary setback, surgical setback. But if you look at this child, if you set this premaxilla back, you're going to create severe hypoplasia of the maxilla. So what we decided to do was the exact opposite. Instead of getting the premaxilla back, we got the lesser segments forward in order to close this space, so that then Dr. Olteritano could do the bone grafting. So again, we used, in this case, the child was between 7 and 9 years of age, so face mask is efficient in these cases. And we brought the lesser segments forward so that there would be less of a gap for the surgeon. And this is the child after the bone grafting. And if you see, the profile is nice and home. We got no retraction of the premaxilla, and that's so important. And this is a child a year after, before the continuation of orthodontics, which is now a little bit further on, with moderate, not perfect ossification, but the fact that the canines still have to come in will help us a lot with the increase of that bone stock. When you have excessive gaps, but the child is much older, well, then you cannot use a face mask any longer, like in this case. And what you can use is a technique that I like very much, which is the ultramic technique that I've shown also in that sort of webinar that we did in India, where Dr. Lisa was with us. We were all together. And Ali Reza, I'm not very good at pronouncing your name. Anyways.
It is okay, dear Maria, that's correct.
Well, again, even in this child, we don't want the premaxilla to come back because it's just as far back as we can get it. So we want the lesser segments to come forward. So how do we get them forward without surgery? We can use this ultramic technique. So we have a double hinge screw. We open and close, open and close, open and close 9 times in order to mobilize the lesser segments. And then using TADs, we pull the 2 lesser segments forward so that we can go from this position to this position. So closing completely the gap on both sides. And the good thing about this appliance is that you can work also in an asymmetrical way. So if there's one side that you want to advance more, you can. And so you can get an almost complete closure, which then once you release the appliance, opens up a little bit, allows the surgeon to do the bone grafting. And this is how close it was. Then when you release the appliance, there's a little bit of relapse. The surgeon can put the bone grafting, and you can see it also on the lateral side. And it's interesting, look at the all this pushing of the lesser segments actually pushed forward also the point A and the nasal spine. So you really have an improvement also of the whole position of the maxilla, not only of the lesser segments. So this was the patient before, the patient after the bone grafting, and the patient at 21 years without any extra orthodontics. You see that these spaces have closed up because the mandible has grown, but he hasn't done anything in the meantime. And he will come back to get a rhinoplasty because he was operated in Bologna, and the nose is really not very nice. But no need for any surgery at the level of the maxilla. Sometimes your orthodontist can help you if your bone graft is not perfect, but you have two teeth that can be moved around. And I'll just give you one example. I've tried to pick one example for each topic that I thought was interesting. For example, this child had a bilateral cleft lip and palate, complete. So he did some early orthodontics with a fan appliance in order to correct the position of these incisors. But then when we got to the second phase with another fan expander, what we did was also CT scan, and we noticed that on the right side, the ossification after gingivoviloplasty was very good, or acceptably good, just a notching of the nose. But on the left side, it wasn't as good. But what we had, if you look at the CT here, is we had a supernumerary lateral incisor. So we didn't need the supernumerary lateral incisor on the right side, but we didn't use the supernumerary lateral incisor on the left side, on the right side. And what we did was move first the small one into the arch, so it brought bone with it, then took it out, and then moved the other, so this supernumerary lateral, into position so that it brought bone with it. And you can see how well this worked if you look at the gingival margin of the completion of, actually a couple of years after the completion of orthodontics. You can see it because he's ready to take his third molars out. And the last topic is, again, the ultramic, but with another objective. The objective is advancing the maxilla so that the surgeon doesn't need to do a Lefort 1 osteotomy, especially when, for example, the patient has a risk of VPI, or when the patient has severe psychological problems. And you can have it in good results in unilaterals, as you see in this kid up there. And the publication that we did on the cleft had a whole group of unilaterals till the completion of growth, and we had an almost 100% success in females, 95%, but in males you have to be very careful, and you'll see afterwards why. But this works very well also with bilaterals. And if you have a child, for example, and bilaterals, it's even more important, because if you all know that bilaterals have an even faster worsening of the position of the maxilla compared to the mandible at about 11 to 13 years of age. So that's when they become adolescents and they really want to look better. And that's when usually we start ultramic. So for example, this little girl had a very small premaxilla with only one incisor. And so the family knew since she was a baby that she would have not grown well, because they have a congenitally hypoplastic premaxilla. So what we did, she had only one central incisor, as you see here. We used the same technique that you've seen before with an open, close, mobilize the whole maxilla, and then bring it forward all the way. So we went from this position to this position, so that then we could start orthodontics, regular orthodontics. And being a female, we know that she's going to have good subsequent growth. This is another micro premaxilla, so another girl with only one incisor. So what we did till she was 12 and a half was only doing one expansion and trying to do extractions so that the canine would erupt in the area where the missing central incisor is, so she wouldn't need too many implants. And then we did the ultramic technique without any screws in the upper arch so that we could move forward the teeth, and she would need only one implant in the upper arch. I finish up with a case which to me is very important, because I think you should also show cases which are not well done. And this is a boy with a bilateral cleft lip and palate, complete. And at the time, I was younger, it was many years ago, and I thought, well, wow, I did a good job. I thought it was a good result. The advancement was more than 5 millimeters, so I really thought I had done a good job, but I didn't take into account the fact that males have a lot more growth during the subsequent years. So what I suggest is always overcorrect. And as you see, now he's 26 actually, but he lives in the States. What I have the pictures from when he was 21. But if you see, he's still like that. There's an edge to edge here, a tendency to crossbite on the right side. So if I had overcorrected him and brought him into a full class 2, or at least half class 2, now he wouldn't be an edge to edge. So in males, please overcorrect. Remember that mandibles keep on growing at least till they're 20, 21 years of age. And so I do thank you for your kind attention, and I hope to see as many Iranians as possible in Milano for the ECPCA Association in 2024. Because of the COVID, we had to move the World Cleft meeting will be moved in 2022, so we had to move in 2024. So thank you for your attention.
Very nice, wonderful presentation. Thank you so much. And any one of our friends, our colleagues, if you have any question, please raise your hand or unmute your mic and start asking your question. Dear Dr. Paris.
Thank you, Professor Moazzini. Thank you so much for a nice presentation. As always, as usual. Dear my colleagues, if you have any questions.
It's too late, they're sleeping.
No problem. But I have got a lot of questions.
Excuse me.
Okay, yes.
I have one
Dr.
question
Mohammadi,
from
please.
Professor.
Yes.
Hi, and thanks for very nice and valuable presentation. I have a question. When will you suggest premaxillary osteotomy for premaxillary setback in bilateral cleft lip and palate patients?
Only if the child is way onto its adolescence, and there is an experienced orthodontist once you have a child who's already 12 or 13, and it's the time, or actually it could be earlier, but it never happened to me. But I suppose even at 10, you might have an idea of how much the mandible is going to grow. But so in that case, if the premaxilla is so far forward that the surgeon cannot do a bone grafting, and the premaxillary setback is sufficient to allow the surgeon to do at the same time the bone grafting, then I would say yes, do it. But if the premaxilla is not that far forward, then I would suggest to come forward before orthodontically with the back, and then allow your surgeon to do some premaxillary setback during the bone grafting, or if possible, none at all. But to be honest with you, in 25 years that I've done this job, I have not seen many cases where I would wish, actually I've probably seen 2, where I would wish the premaxilla to be further back, because it just goes back on its own so fast during growth that it's very rare, very, very rare. So I would judge it on the mandible and do a sort of anecdotal design of how much that mandible is probably going to grow.
Thank you so much. And
Somebody-
what is your, excuse me, what is your opinion about lip adhesion before nasoalveolar molding?
Oh, I think it doesn't make much sense, because we do nasoalveolar molding to avoid an extra surgery, because we don't know yet if all these early surgeries can be detrimental for neurological development. So I don't think you need it. I would definitely not suggest it. I think it's an extra surgery that you really don't need.
Thank you so much.
Professor Moazini. One of my colleagues has a question. Dr. Abbasi has a question. He asked that, he asked that, do you propose applying customized DO?
Excuse me?
Customized DO, distraction.
What's your idea about the customized DO?
Oh, I think that in non-children, like in at the completion of growth, it's extremely. Eric Leo has done it many years ago, and I think it's great. But if the child is still growing, you can get those 8 millimeters. Well, if you need 20, of course, you need to do distraction osteogenesis or at least osteotomies of the lesser segments. But if the child is still growing and you have a gap of 10 millimeters, you can do it orthodontically. So that was a point of of this talk, the fact that sometimes you don't need to do, because then you need to do the distraction. So it's one surgery. Then you have to take away the distractors. They could be they could be dental devices, so that's not a big problem. But then you have to do the surgery for the graft. So it's 2 surgeries instead of 1. So the idea is, if the orthodontist helps you, you only do 1 surgery with less scarring, less risk, less infection, less everything.
Okay, thank you.
Thank you. Thank you, Maria. I want to ask you a question regarding the anterior maxillary dissection, AMD. You're using your customized or a prefabricated?
For
anterior maxillary distraction, AMD.
The intrusion? No.
Yes. No, for the distraction of the posterior maxilla towards the anterior.
Oh, that's customized. Yes, I take impressions and then make it as if it were a normal expander, but it's a 2-hinged expander that you have to open and close for many weeks, so that the sutures are completely open. You feel the maxilla is mobile, and then with springs, you bring everything forward.
Yes.
So
and another
thing is customized, yes.
Customized. And is it in Italia they use once in surgery, do the palatal surgery and dental alveolar as well as lip together in one setting or not? I have seen some country they are starting doing like this after the NAM.
You mean primary periosteoplasty or palatal surgery?
Palatal surgery along with the lip also together.
Yes, in Milano we do soft palate for sure, and lip and nose, and then if the palate is narrow enough, also the hard palate, but not the alveolar surgery. Whereas many groups like the Cutting and Grayson group, the New York group, does the NAM and then the periosteoplasty directly, and then the palate. So we do what you said, so the opposite. We prefer doing lip and nose and soft palate, and if possible, also the hard palate. At 6 months.
Thank you so much.
Okay, thank you. Another question, one of my colleagues asked that, is there any limitation, age limitation for NAM?
I think after 4 months, you don't really get very much. Although, to be honest with you, I've never tried later than 4 months. But if I compare the results that I got in children that are 1, 2, 3 weeks of age, compared to the ones that came too late at 3.5 months, it's a lot harder. And then you have to continue longer. So like that girl that you've seen with the premaxillary protrusion had come too late, and that's probably one of the reasons. And we did the NAM starting at 3.5 months, and it took 7 months to do a proper job with the nose. So I have the impression that after 4 to 5 months, it's just too difficult to get the premaxilla back. Everything ossifies.
Okay, so you mean that you started the NAM almost 2 weeks after the birth?
Or as early as possible. If I
early as possible.
And take the impression when the baby's 2, 3 days, 4 days, then I start as early as possible. Yes. As soon as we take the impression.
Okay. Let me check. Is there any questions?
If I may, I have a question, please. I wanted
yes, of course.
Yeah, I wanted to upright my hand to show. دوربینم اجازه بدی روشن نکنم.
آقای سینگر اشکال نداره آقای دکتر.
Thank you for your wonderful presentation. And I remember 2 years before you had a very wonderful lecture about first surgery approach in orthodontic surgeries. And I exactly remember, I enjoyed so much. And yeah, and now maybe I'm a little slow to understand. As I understand from your lecture that maybe with your approach in orthodontics for these patients, and it is only one surgery for grafting is enough and nothing else is not necessary. Am I right?
What do you mean? In terms of alveolar ossification, most of the patients that we treat in Milano don't do bone grafting, but do gingivoveoloplasty at 2.5 years of age. And we've published the data. We have about 97% ossification, so a very high amount of ossification, very low failure. But the patients that I've shown were mostly operated elsewhere, and so had not gotten any early secondary gingivoveoloplasty. So they did bone grafting, but it was a one-step bone grafting, so both sides at the same time. Is that is that a question or?
Of course, you completed my second question that I was going to ask. But then, you know, I want to clearly know, and I did it rightly, that then with this method, there is no need to surgery. Am I right? No need to surgery. I mean orthodontic surgery, not gingivoplasty or something.
Well, no. With this technique, in males, and plus I have the long-term results only of unilaterals, not of bilaterals. But in unilaterals, we know that in females we can almost eliminate. So 95% of the girls do not need, that have been treated with this technique, do not need orthodontic surgery, whereas only 80% of the boys, so 20% fail and then need orthodontic surgery. I do not have the results of bilaterals because the numbers are not so high. I don't know if giving numbers would make much sense, but I would say that in bilaterals, it's the efficiency is very high in females because you do it right when then the mandible stops growing. But in males, I'm not sure, even overcorrecting, there would still be a doubt. If it's a mandible that grows a lot, I would still be in doubt. So there still is some orthodontic surgery left. But Professor Bruzzati liked the technique a lot, because what happens when with a protocol you need very little orthodontic surgery, people say that the surgeon is very, very good. They don't say that the orthodontist is good. So Professor Bruzzati was very happy.
Yeah, very, very wonderful. Maybe the movability of the, in the cleft patients, the movability helps the patient to, you can move the segments and commit surgery. Am I right? Did I get it?
If what you mean in cleft patients, it works better than in non-cleft patients, you're absolutely right.
Yeah, yeah.
Because I just published the long-term results in non-cleft class 3 patients, and you never get that much, that amount. So in cleft patients, you have an average of 5.7 advancement of the maxilla, whereas in non-cleft patients, it's 5 more or less. So it's almost 1 centimeter less, which is a lot.
Of course, maybe it's changed the principle of orthodontics, because left patients, maybe, the paradigm is shifting toward non-surgical approach, and it's wonderful.
Thank you.
Thank you so much. Yeah, I think I heard a question, the limitation of this method, and I thought that it was about what age is more suitable for this practice, or when what age we cannot do it.
What I use as a method of judgment is the maturation of the vertebrae. So it should be, the 3rd vertebra should be already developed, but not the 4th. You also use, like in females, the menarche shouldn't have been for the time between when you start and menarche shouldn't be longer than 6-7 months, maximum 1 year. And if you want to try no matter what, now what I do is in every single patient, I take a CT scan to see the sutures. So I want to see the midline, mid-palatal suture up to where you see it. The zygomatically-maxillary sutures are so important for coming forward, and the pterygomaxillary sutures. If the child, let's say, is 14 years of age, has had menarche a year and a half before, but the sutures are all open, then I do it anyways. Otherwise, I just tell the parents that it's too late and they have to wait for surgery.
Thank you. Thank you very much.
Thank you.
You're welcome.
Thank you, Dr. Singari. And also we have another question from my colleague, Dr. Abbasi. He asked that if we don't have any dental anchorage in premaxilla, what's your solution to controlling the premaxilla?
You mean in the vertical?
Yeah.
Vertical excess?
Yeah.
I would probably, if there is no other reason, I would probably wait for the teeth to come in. Oh, if you said no teeth at all, no permanent teeth?
Yes.
No anchorage, or maybe teeth. Okay. Yeah.
Maybe teeth, I would wait for the permanent.
Yeah,
Okay.
he's asking any dental anchorage in the premaxilla.
And then you need your surgeon.
Okay, you need the surgery to intrusion the premaxilla.
Maybe you could put screws in the premaxilla, but yeah, probably a couple of screws in the premaxilla and lift it. I've never done it, but
Okay.
yeah.
Otherwise, so you're waiting for other teeth to grow.
If there are permanent teeth, I would wait for the permanent teeth.
Okay.
But I've never had a case of a premaxilla with no teeth, so I don't know. It could be an option, putting a couple of screws and lifting it up, but I don't know. I've never done it. So
Okay. Thank you.
You're welcome.
Okay, my colleagues, any other questions?
Everybody is saying thanks to you for your wonderful presentation.
Thank you.
Once again, we should say and hope we will get the opportunity for other times to have you in the meeting. And if it is possible for the surgeon who have done your works, if you introduce and he sends his email, we can arrange another meeting with the surgeon also.
Absolutely.
To completely.
I would be very happy, sure.
Sure. Thank you so much. You can send it to me. Send it to me. I will hand over to Dr. Parhiz to arrange it.
I shall.
Thank you.
I shall.
Thank you. Thank you so much. And hope all this situation will over and we will have you in Iran again.
Let's pray. Yes.
Yes. Thank you so much.
Thank you so much, Professor Moazzini. Tonight we have some guests from other countries, and we were waiting for Dr. Nasser, but unfortunately he didn't. Yes. Yeah, I want him to join us, but unfortunately, no, unfortunately, he's not in the group. I was waiting for him,
I couldn't see,
but I think he's so busy.
He's too busy.
Thank you again. Yeah.
You're welcome.
Thank you again. I hope we can have another webinar with you and Dr. Nasser.
Yeah, that would be great.
Yeah.
Yes.
Yeah.
Bye.
Thank you so much.
Thank you. Thank you so much.
Night.
Thank you.
Bye.
And thanks to everybody. Thank you so much.
خدا نگهدار همگی.
Good night.
Good night.
Good night.
Thank you. Take care.
Thank you. You too. Absolutely.
Sure. Thank you. آقای دکتر خیلی ممنون.